at the central nervous system, particularly the ventricles and the midline structures. The ventricles are measured in the axial plane at the level of the atrium, and normally the width should be less than 10 millimeters. But it's important to note that until the 23rd week of gestation, there may still be physiologic disproportionate enlargement of the occipital horns. In this case, this one is in a 32-week fetus. We can see there's severe dilatation with low signal intensities within the ventricles, suggestive of a hemorrhagic product causing the obstruction. Also in the midline, we can check for the corpus callosum and the cavum septum pellucidum. The corpus callosum, as shown here, should be well developed by the 28th week of gestation. Also, we can see the tentorium cerebelli and the brainstem. So the anterior flexion of the pons should be well visualized. In cases of a consideration for a agenesis of the corpus callosum, there are indirect signs such as the absence of the cavum septum pellucidum. There's straight parallel lateral ventricles, known as the Viking helmet sign, and there may be dilated occipital horns, known as colpocephaly. These are signs of corpus callosal agenesis. Again, looking at the brainstem, in this case, we have a patient with a cerebellar hypoplasia with flattening of the anterior pontine flexion, indicative of a dysplastic brainstem. So after looking at the midline structures, we can also look at the cerebrum based on its location and gyration. And early in gestation, we should see 3 layers, the germinal matrix, the cortical plate, and an intermediate layer in between. And as the fetus matures over the weeks, okay, we should see the complete location at 34 weeks. So we can actually misdiagnose this as lissencephaly. So we should know the age of gestation and how the fetus should normally mature. In this case, this one is at a 20-week patient wherein screening for lissencephaly was being done, and then just following it up at this one at 32 weeks, showing the normal maturation of the brain. Also, we can look at the posterior fossa. Here we can see the tegmentovermian angle measured in the midline sagittal image. The TV angle is formed by the lines of the anterior surface of the vermis and the dorsal surface of the brainstem. So this angle should be normally 0. And if it's enlarged, it may be indicative of an elevated vermis due to developmental anomalies of the cerebellum. Also, the cerebellar transverse diameter is measured in the axial view. It's also a useful tool for the biometry scoring for the patient. Also, the cisterna magna, which is measured in mid-sagittal images, should be less than 10 millimeters. And it's enlarged. In this case, it may indicate a Dandy Walker spectrum. If it's obliterated, it may be indicative of an Arnold-Chiari malformation. So in these cases, we should also look at the spine for any associated possible myelomeningocele or a possible encephalocele. Next, we look at the face and the neck. Okay, so on sagittal images, this one is the beta FFE images showing a patient at 28 weeks with the amniotic fluid outlining the facial profile. So we can see the nose, the lips, and the chin. And this one is the palate that separates the fluid-filled oropharynx and the hypopharynx. So any obstruction may be easily seen on the MRI. And for example, in this case, a patient with craniofacial deformities with holoprosencephaly, we see a profoundly small head with frontal sloping, abnormal face profile. There's semilobar holoprosencephaly with fusion of the cerebral hemispheres. There's partial agenesis of the corpus callosum at its anterior aspect. And there's also cerebellar vermian hypoplasia. Other structures that we can look for in the face and the neck include possible goiters or teratomas in the anterior aspect of the neck. So in the goiter, we can see that it should have a characteristic high signal intensity on T1 since it's of thyroid origin as compared to the other masses which may be cystic. So it should those masses will be hyperintense on T2. So in the lateral and posterior aspects of the neck, you might see the lymphatic malformations. Um, we can see how these cysts are able to infiltrate the surrounding structures. And in cases of an encephalocele, we should be able to see a cranial defect or a bony defect wherein there is a herniation of the encephalocele. Next is the fetal thorax. So normally the fetal lungs have homogeneous, moderately high signal intensity on T2, and the sagittal and coronal images, we should be able to see the diaphragm that clearly separates the abdominal structures from the thoracic structures. Now, there may be several cases that can be useful for doing the fetal MRI, such as the congenital pulmonary airway malformations, PPS, diaphragmatic hernia, and hydrothorax, which result in a decreased fetal lung volume, resulting in pulmonary hypoplasia. So there are methods for measuring the fetal lung volumes. One is the manual tracing method, which you outline the region of interest of the lungs, and then tracing this and then multiplying it by the slice thickness, we can come up with the volume in ml. And also the semi-automated method using softwares, and then comparing these fetal lung volumes with established data showing how each fetal lung volume is computed based on the gestational age. We can compare to the established data and see if it's below this expected values. In assessing for congenital diaphragmatic hernia, we can look at several ratios. First is the lung area to head circumference ratio, and we have these online calculators that can help in interpreting and formulating the ratios. So lung area to head circumference is based on the longest diameter of the lung in 2 dimensions, and then comparing it with the head circumference. And decreased ratio may indicate a poor prognosis. Also, the other ratios can also help in coming up with the percentile for the prognosis for these patients. So, for example, in this one, we can see the diagram of congenital diaphragmatic hernia. And then we're going to measure the lung area of the contralateral lung, the one that's not affected, and compare it with the head circumference. And in this study, they compared the observed to expected MRI fetal lung volume with the ultrasound, also doing the lung to head ratios at different gestational ages in patients with congenital diaphragmatic hernia. And they found that there was significant correlation between MRI and ultrasound, particularly for the left-sided diaphragmatic hernias, and it's best done before 32 weeks age of gestation. Another pulmonary problem is the congenital pulmonary airway malformation. In this case, we look at the size or the volume of the actual malformation and compare it to the head circumference. Again, these may be indicated by the ratios showing how how these patients should be followed up. Next is the abdomen. So in doing the abdomen, we can look at the coronal images as shown here, and on the sagittal images, wherein the liver is hypointense on T2, and the fluid in the stomach and the small bowels has high signal intensity. And the bowel loops are seen better here on the sagittal FFT images. These are less prone to motion artifacts. And in looking at the liver, we can look at the T1 sequences wherein the liver is more moderately hyperintense. And there's also higher signal intensity of the hepatic vessels caused by the unsaturated blood within the vessels. The fluid in the stomach and the small bowels are hypointense on T1, while meconium are hyperintense, so we can check if there's already meconium. After 13 weeks, meconium is produced, and it migrates from the small bowel to the colon. And at 20 weeks, we can see if there's functional obstruction of the anal canal and the meconium accumulates. And so the proximal intestines are hypointense on T1 and hyperintense on T2 because of ingested amniotic fluid, while the colon is T1 hyper and T2 hypo because of the meconium. And so at 20 weeks, we should see these normal measurements of the small and the large bowels. And at 35 weeks, they have increased in size. This is an example of an omphalocele shown in these sagittal images, showing there's also herniation of the liver and other soft tissues. So the other structures of the abdomen, such as the spleen, which should be detected by 20 weeks, have also homogeneous signals that are, as the patient matures, should decrease in signal. Also, the gallbladder, the cystic structure below the liver, should be seen by 18 weeks. And normally, we should not see the biliary ducts during the prenatal checkups unless there's an obstructive process. Looking at the genitourinary system, we can check for the renal length, the signal intensities on T2, and the ADCs, which should change as the fetus matures. And the renal cortex hypointense relative to the medulla on T2. And we can see cystic lesions, obstructive uropathy, such as posterior urethral valves, renal tumors, and urinary tract anomalies. In this case, we see a posterior urethral valve causing a dilated urinary bladder, and it's obstructed by the PUV, and it assumes the keyhole appearance. Okay, in this one, we see a bilateral polycystic kidneys with bilateral renal enlargement, as shown by the black arrows, increased signal intensities of the renal parenchyma, and cystic dilatation of the collecting tubules. Also note, in this case, we can see hypoplastic lungs, an absence of the urinary bladder, and oligohydramnios. So it's a spectrum of diseases seen in bilateral polycystic kidneys. Another particular case we can look for is the sacrococcygeal teratoma, particularly because fetal MRI has an impact on how these patients are managed. And these generally appear as mixed solid and cystic with calcifications in 50%. And there are 4 types of sacrococcygeal teratomas. The most common is the type 1, wherein there's a complete external teratoma with minimal extension into the presacral region. And in the type 4, it's purely presacral. So aside from the fetus, we can also assess the pregnancy-related structures such as the placenta, which should appear moderately hyperintense on T2, and it should appear homogeneous on around 19 to 23 weeks. And as the patient fetus matures in advanced gestation, there's increase in the lobules and the T2 signals. And also looking at the umbilical cord and umbilical cord and its insertion into the placenta and the amniotic fluid if there's oligo or polyhydramnios. So in this sample, we can see the placenta showing increased signal intensities and heterogeneous with lobulations at 32 weeks. So using a systematic approach to fetal MRI, we can recognize the developing fetal anatomy, detect subtle anomalies, and evaluate for complex lesions that may be difficult to visualize on the ultrasound. And it aims to facilitate management of these patients and guide any prenatal therapy that can be done. And in this study, published in the American Journal of Neuroradiology, it compared the prognostic accuracy of the fetal MRI and the postnatal neurodevelopmental outcome. In this case, they compared how the patient, the fetus, in the prenatal period was assessed compared with the postnatal prognosis based on the development of such as the development of seizures in the postnatal period. They found a 93% agreement between the prenatal and the postnatal imaging diagnosis. So there's good correlation with the fetal MRI and the postnatal period. And these are my references. Thank you.
Thank you so much, Dr. Carl Solidum. So I also see we have attendees from NKTI and Baguio General Hospital. Welcome po. So just to recapitulate and emphasize some points. So, an fetal MRI is indicated when there is an abnormality on ultrasound that is not clearly defined and more information is sought in order to make a decision about therapy, delivery, or to advise a family about the prognosis. And in cases where there is abnormality identified on ultrasound and the attending physician would like more specific information using MRI in order to make decisions about care. So, an example would be the calculation of the fetal lung volume in cases of congenital diaphragmatic hernia. So, what are the advantages of MRI over ultrasound? So, in MRI, the visualization of the fetus is not significantly limited by the maternal obesity, the fetal position, or oligohydramnios. And the visualization of the brain is not restricted by the ossified skull. So, like in any MRI procedure, so before doing the MRI, of course, you have to screen the mother for presence of ferromagnetic devices or implants. So, at what gestational age should you do the fetal MRI? So, imaging in the first trimester is not recommended as this is the time of organogenesis. The American College of Radiology suggests imaging after 18 weeks due to the unknown effects of higher magnetic field strength and potentially prolonged imaging times. However, there are no current evidences that exist to show that fetal MRI is harmful to either the mother or the fetus. So the use of gadolinium has not been adequately studied in pregnant human patients and is not used during pregnancy unless absolutely necessary, especially during organogenesis. And ultrasound imaging is complementary to the fetal MRI and is helpful at the time of MR imaging. So it is always helpful to have the report as well as the images from the recent ultrasound for, for correlation of the biometric measurements and anatomy. Now for the technique, so the mother should fast 4 hours before the exam to reduce bowel peristalsis artifacts and to prevent postprandial fetal motion. And the mother should empty her bladder immediately before the MRI procedure. So ordinarily, you can scan the mother in a supine position, but a left lateral decubitus position is usually preferred during late pregnancy to prevent compression of the IVC by the gravid uterus. So no maternal sedation or fetal sedation is necessary in doing the fetal MRI. And for proper interpretation of the fetal MRI, the interpreting radiologist should be familiar with the normal developing fetal anatomy. So, for example, in the brain, um, you should be aware of the multi-layered appearance of the cerebral parenchyma, the knowledge of the timing of sulcal appearance, the myelination, and changes in ventricular size. For the other organs, such as the lungs and the kidneys, so with advanced gestation, it would show significant changes in volume and T2 signal intensity. Fetal MRI will not be complete without evaluation of the placenta, the umbilical cord, and the amniotic sac. So these are parts of the fetal MRI examination. So, an accurate interpretation of fetal MRI will provide valuable information that would help in prenatal counseling, facilitate management decisions, guide therapy, and also in research studies. This is fetal MRI is being used. So now I would like to give the floor to Dr. Janelle Alexa Uy, who will present to us three local cases we have had in St. Luke's Medical Center. Alexa, you may now share your slides.
Okay, Doc, we'll share po my slides. Good evening, I'm Jana Alexa, a Pediatric Radiology Fellow, and I was tasked to go through some fetal cases from our institution and discuss them one by one. Case 1 is 24-year-old G2P1 female with a single intrauterine pregnancy and cephalic presentation, AOG of 30 weeks and 3 days, coming in for a congenital anomaly scan. Ultrasound showed a 3.4 cm interruption in the bony skull at the midline parietal area that communicates with the multiloculated cystic mass measuring 7 by 7 by 4 cm with septal thickness of 0.5 to 0.7 cm. The cerebellar vermis is absent and thus a communication between the fourth ventricle and cisterna magna is visualized. Cisterna magna measures 2.8 cm. Splaying and flattening of the cerebellar hemispheres are also noted. Lateral ventricle measures 1 cm. For the report, we have an encephalocele and Dandy-Walker malformation. The rest of the scan appears normal. For the fetal MRI findings, there's a loculated septated CSF-filled structure at the vertex, corresponding to the previously seen ultrasound finding, measuring approximately 7 by 8 by 4 cm. It appears to be protruding from the anterior fontanelle, with some cerebral parenchyma herniating into the sac. This is compatible with an encephalommeningocele. A retrocerebellar CSF collection is also noted, measuring about 4 by 5 by 6 cm. The tentorium and likely the torcula are elevated. No herniation into the superior cervical canal is observed. The cerebellar hemispheres and brainstem are compressed. The vermis is not identified. These findings are reflective of a Dandy-Walker malformation. Moreover, the corpus callosum is not well delineated. The lateral ventricles are slightly dilated, and there's also suggestive partial fusion of the thalami. The spinal canal is grossly unremarkable. No evidence of myelomeningocele is seen. The impression, so we have an encephalommeningocele, a Dandy-Walker malformation, a corpus callosum that's not well delineated, with lateral ventriculomegaly, and partial fusion of the thalami. The findings are compatible with the disruption of the brain formation during the stages of dorsal and ventral induction. So what are cephaloceles? These are defects of the dura and overlying skull. They can be classified as primary if there's a developmental and congenital context, and secondary if they occur after trauma or surgery. They're usually due to the failure of neural tube closure, and they consist of herniation of intracranial contents. We call them meningocele if they're only meninges and CSF, encephalocele or encephalommeningocele if it includes brain tissue, and encephalocystocele if there's already ventricle. It's a relatively rare disease and may occur in the setting of a number of syndromes, such as trisomies, Walker-Warburg, Meckel syndromes, and Dandy-Walker malformation, which was seen in our case. So this is the retrocerebellar cyst that was characterized by aplasia or hypoplasia of the cerebellar vermis, cystic dilatation of the fourth ventricle, enlargement of the posterior fossa with an elevated tentorium that can have associated anomalies such as agenesis of the corpus callosum. 80%, however, of the cephaloceles are actually non-syndromic and have an isolated form. So this is a table of classifications from Albright, Leland et al., showing primary cephaloceles divided into 3 major types. For our case, it can be classified as a primary cranial vault cephalocele, particularly at the interparietal or anterior fontanelle region. So this is at the vertex. Cranial vault cephaloceles can occur anywhere in the skull. So in North America, it's commonly present in the occipital region. In Southeast Asia, Central Africa, and parts of Russia, it's commonly seen in the frontoethmoidal region. For vertex cephaloceles, so those seen in the midline or interparietal region, they're not that common. More often than not, if they are seen in this region, it's the atretic form. So this typically appears as a midline subcutaneous nodular cyst with rudimentary meningeal tissue and underlying venous anomalies. Large lesions, such as that in our case, and this sample case online on the right side, are rare. Limited case series are present in literature. For imaging, in ultrasound, we usually see a cyst protruding from a calvarial defect, or if there's herniated brain, there could be a solid mass or tissue protruding with it. High-resolution CT is used to define the contents and to display bone anatomy. MRI imaging is the best imaging modality for defining the contents prior to surgery. We can assess the intracranial connection, determine extent of cerebral tissue or displaced brain, differentiate lesions, and detect draining veins via echoplanar imaging. Prognosis depends on location, severity, presence of dysplastic brain tissue, and associated abnormalities. So for giant occipital encephalocele, they have more underlying malformations and hydrocephalus, so they have poor prognosis. For parietal encephaloceles with hindbrain malformation, poor prognosis are seen than those without. Management is surgical treatment, so we have excision of the sac and repair of the dural defect after replacing the viable brain tissue into the cranial cavity. The end result of surgery is determined by the underlying brain involvement and presence of absence of the congenital defects. For case 2, we have a 32-year-old G1P0 female with a single intrauterine pregnancy and cephalic presentation. AUG is 36 weeks 3 days, and she came in for a second and third trimester ultrasound. Ultrasound showed a heart that is placed to the right hemithorax, and there is a left thoracic mass measuring around 5 by 3 by 4 cm arising from the abdominal cavity through an apparent defect in the left posterior region of the diaphragm, with intralesional cystic areas, possibly dilated bowel loops. The stomach is noted above the diaphragm, and the left kidney cannot be definitely identified, either in the abdominal or chest regions. So for the report, we have a thoracic mass on the left, probably stomach and bowels, to consider diaphragmatic hernia, and possible renal dysplasia on the left. Fetal MRI findings show at the fetal chest several bowel loops, so fluid-filled small and large intestinal segments within the left hemithorax, with associated compression of the left lung anteriorly, measuring around 3 by 3 by 4 cm. Notice in the sagittal images here of the right and left diaphragm, there is a defect in the form of a posterior discontinuity of the left diaphragm. There's a reniform structure that could possibly represent the small left kidney insinuating partially into the posteriorly located diaphragmatic defect. The entire fluid-filled stomach and spleen are noted above the diaphragm and appear to be positioned laterally and anteriorly respectively within the left hemithorax. The heart is deviated toward the right hemithorax with compression of the right lung. The liver remains to be on the right side of the abdomen. The gallbladder is not delineated, probably contracted. The fluid-filled urinary bladder is well seen. The right kidney appears normal in size and configuration. For computation, we have the observed lung-to-head circumference ratio, which was proposed to identify fetuses that have a poor prognosis. So this is an indirect assessment of fetal lung volume, which estimates residual lung capacity and predicts pulmonary hypoplasia. So the lung area contralateral to the CDH can be obtained by taking the product of the longest two perpendicular linear measurements of the lung measured at the level of the four-chamber view of the heart on a transverse scan. The product is then divided by the head circumference to obtain the LHR. One can also use the tracing method, so tracing the limits of the lung contralateral to the CDH and then dividing it by the head circumference. In some studies, it was found out that manual tracing of the lung is more reproducible compared to the longest diameter method, which tends to overestimate the right and left lung areas. For the interpretation, if LHR is less than or equal to 1, prognosis is poor. It's even poorer if the liver is in the thorax. If it is between 1 to 1.4, ECMO is needed. And if it is greater than 1.4, prognosis is good. We also have the observed over expected lung-to-head ratio, where the observed LHR is expressed as a percentage of the expected mean for gestational age. So we can compute it by getting the observed LHR, dividing it by the expected LHR, and multiplying it by 100. These are the formulas to get the expected LHR for the longest diameter method and the tracing method. Interpretation. So in patients with isolated CDH, an observed or over-expected LHR, which is greater than 45%, usually indicates 100% survival in patients. If it is less than 25%, only few survivors will be present. We also have the quantitative lung index, which is the QLI. It's a new parameter to describe right lung growth. This is how we solve it, and it connotes that a small lung is basically defined as a QLI of less than 0.6. Of course, if you have a stable internet connection, you can also just compute it via an online calculator. So we can go to this website, perinatology.com, look for the ratio needed, and then input the necessary data, so the gestational age, whether the hernia is on the left or right side, the longest diameter measurements, the tracing method measurements, as well as the fetal head circumference. And then you'll get the numbers and ratios you'll need. So for this patient, the observed lung to head ratio is 2.4 via tracing method, and the observed over expected LHR is approximately 74%. The quantitative lung index is about 0.7. So we have the impression of a buccal hernia with bowels, stomach, probable left kidney, and spleen herniating through the left-sided posterior defect. The liver and the right kidney remain intra-abdominal. The LHR and observed over expected LHR values suggest a good prognosis and survival rate. So what are congenital diaphragmatic hernias? These are lesions from a defect in the diaphragmatic musculature, occurring in 1 out of 4,000 births and traditionally classified based on location. We have the posterolateral buccal hernia, anterior Morgani hernia, and central hernia. The buccal hernia usually occurs secondary to failure of fusion of the pleuroperitoneal membrane to the remaining primitive diaphragm. 80% of these are left-sided, and bilateral hernias occur rarely. 15% have a hernial sac. Survival rate is around 70%. It's lower among patients with syndromes, organ malformations, and severe isolated CDH. It's higher among patients diagnosed postnatally as compared with patients diagnosed prenatally who were observed to have more severe disease. Four prognostic factors are as follows. So we have the large mediastinal shift, low lung volumes, liver herniation, intrathoracic location of the stomach, asymmetric size of the cardiac ventricles, polyhydramnios, syndromes and anomalies, and bilateral CDH, which is usually fatal. Prenatal imaging, so we already mentioned how the ultrasound and MRI can evaluate for severity of CDH and provides important prognostic information. So the parameters that we can get are the lung-to-head ratio, total lung volume, and if applicable, the percent liver herniation. MRI is more accurate in predicting survival than ultrasound. It's important to note that pulmonary hypertension is a common finding in newborn infants with congenital diaphragmatic hernia due to structurally and functionally abnormal pulmonary vessels. So this may be predicted using the modified Macoun index, wherein the right pulmonary artery diameter is added to the left pulmonary artery diameter, and then this is divided by the aortic diameter. If it is less than 0.8, there's a risk of developing pulmonary hypertension, which is high, and then if this is more than 1, the risk is low. For our patient, we were not able to solve for this because we could not delineate or locate the left pulmonary artery diameter. So we didn't want to just assume that it was 0. For postnatal imaging, we have the chest radiograph, wherein you can note a opacified hemothorax with cardiomediastinal shift, intra-abdominal solid organ herniation, and an abnormal position of catheters and tubes. For the ultrasound, we can delineate the vena cava and the hepatic vasculature and identify herniated solid organs before surgery. For CT and MRI, they can play a role in excluding a congenital lung anomaly. Management in the past few decades has shifted from emergent surgical repair to initial medical management, followed by elective repair. There has been improved outcomes when pulmonary hypoplasia and hypertension are treated prior to repair via the hemodynamic ventilatory support and correction of metabolic abnormalities with the use of ECMO, for example. Surgical repair is through the transabdominal or thoracoscopic approach, wherein herniated abdominal viscera are repositioned within the abdomen and the defect is closed. For case 3, we have a 25-year-old G2P1 female with a single intrauterine pregnancy and cephalic presentation. AOG is 23 weeks and she came in for a congenital anomaly scan. The ultrasound shows the right lung measuring about 5 by 5 by 5 cm which is converted into a heterogeneous mass with multiple sub-centimeter cystic spaces, the largest of which measures 0.3 cm. The mass seems to be supplied by a branch of the pulmonary artery, suggestive of congenital pulmonary airway malformation, or CPAM. There is mediastinal shift to the left, the thoracic aorta and the heart are pushed as well to the left, and there is decreased left lung volume. So for the report, we have a CPAM on the right lung, cardiomediastinal shift to the left, and a small left lung. Fetal MRI findings show an abnormal increased signal with fairly uniform tiny fluid-filled cysts in the superior right lower lobe, measuring about 3 by 3 by 2 cm, representing the known CPAM type 2 of the patient. No dominant cyst is identified. The heart is fairly midline with the apex to the left. The diaphragm is intact, the liver is on the right while the spleen and fluid-filled stomach are on the left. The bowels are intra-abdominal in location. The gallbladder, kidneys, and urinary bladder are seen and unremarkable. For CPAM, we have the CPAM volume ratio, CVR, which was proposed to evaluate fetuses at risk for hydrops and possible intervention. So we have to get the volume of the mass normalized for gestational age. The maximal length of the CPAM in sagittal view is used to measure the length. Perpendicular to this axis at the maximal width of the lesion, the width and height of the CPAM are measured. The CPAM volume is estimated using the formula for a prolate ellipse, so it's length times height times width times 0.52. The CVR is obtained by dividing the CPAM volume by the head circumference measured in cm. For the interpretation, a CVR of more than 1.6, or if there's a CPAM with a dominant large cyst defined as a cyst greater than a third of the size of the CPAM, there's usually increased risk of developing hydrops, so these patients should be followed up 2 to 3 times per week. A CVR of less than or equal to 1.6 shows a risk of hydrops that is low, especially in the absence of a dominant large cyst. So we can also use the perinatology.com online calculator, input the necessary information for the CPAM volume. And for our case, the CPAM volume is about 12 cm cubed or ml, and the CPAM volume ratio is 0.38, reflective of a low risk for developing hydrops. For the lung volumes, on the right we have 53 ml, on the left 21 ml. And for the CPAM right lung volume correlate, so the CPAM is around 22% of the right lung volume. In CPAM, it's quite similar to congenital diaphragmatic hernia because there's a significant risk of having pulmonary hypoplasia due to the compression of the lung tissue. So actually we can also calculate for the LHR, lung head ratio, to estimate the residual lung capacity and prognosis. So again, we input the necessary information on the calculator. For the case, the observed left lung to head circumference ratio is 3.3 and 2.5 using the longest diameter and tracing methods respectively, suggesting a good prognosis. So for the impression, we have the CPAM type 2 on the right, low CVR reflecting low risk for developing hydrops, and high LHR, suggesting good prognosis. So what is CPAM? It's congenital pulmonary airway malformation, previously known as CCAM. So it's the most common congenital lung abnormality. It's a hamartomatous lesion characterized by abnormal growth of terminal bronchioles containing cystic and solid tissue. So it's typically unilobular with microcysts or macrocysts lined by respiratory epithelium, an abnormal communication with the tracheobronchial tree, blood supply from the pulmonary arteries, and venous drainage from the pulmonary veins. We have classifications for the prenatal imaging, which is the AD6 classification, which is based on the fetal imaging appearance and gross anatomy. So type 1 is macrocystic CPAM, wherein there's one or multiple large cysts more than 5 mm. And type 2 is the microcystic CPAM, wherein there are cysts less than 5 mm, which may have a solid appearance. Another classification is the Stocker's classification, which is used in postnatal imaging. We are quite familiar with this. It's based on cyst size and underlying histologic resemblance to the bronchial tree and air spaces. It's important to note that type 0 is not compatible with life. Types 1, 2, and 4 are primarily cystic, and type 3 is predominantly solid adenomatoid tissue. For imaging, so the ultrasound appearance depends on histology. Macrocystic CPAM appear as multiple non-connecting cysts, while microcystic CPAM may appear homogeneously echogenic and usually more echogenic than the adjacent lung. MRI is useful in delineating the lung mass and amount of residual normal lung, so you can identify cysts and solid components. Some CPAM may appear to resolve completely prenatally, and then have a normal appearing chest radiograph postnatally, but CT can often help in identifying a residual mass. For the prognosis, it's typically favorable with spontaneous decrease in size in up to 90% of cases. If no hydrops exist, the outcome is excellent. If hydrops develops, then the fetus may die without intervention. For management, there's a generalized consensus, so for symptomatic CPAMs, they should be resected via lobectomy, regardless of the patient's age at presentation. But there are no current consensus on the timing of or need for resection of prenatally diagnosed and symptomatic and small CPAM lesions. So they may be done with a non-surgical strategy like use of steroids with imaging follow-up, or some may opt for a surgical resection before 1 year of age. This is due to the potential risk of associated complications such as infection, pneumothorax, and small risk of malignant transformation, especially in CPAM type 1. So that's the end of my presentation. I hope you learned a lot, and these are my main references.
Thank you so much, Alexa, for presenting those 3 interesting fetal MRI with congenital anomalies. So, 3 cases were presented to us. The first case was a patient with a very large encephalomeniнгocele as well as a Dandy-Walker malformation. So the second case is congenital diaphragmatic hernia. So in cases of diaphragmatic hernia, there are values measured or calculated, such as the observed to expected lung to head ratio, which correlates with the degree of pulmonary hypoplasia. So the lung to head ratio can be calculated using ultrasound, but measurement using MRI has been found to have a slightly higher prognostic accuracy than with ultrasound. And the development of pulmonary hypertension in cases of hernia may be predicted using the modified McGoon index. The third case that was presented was CPAM, or congenital pulmonary airway malformation. So in patients with CPAM, using ultrasound or MRI imaging, you have to calculate for the congenital pulmonary airway malformation volume ratio. So this is an indicator that has been proposed for the evaluation of fetuses at risk for hydrops and possible intervention. So as we have seen, fetal MRI is an interactive scanning of the moving fetus. Fetal MRI should be carried out in a center with up-to-date MRI scanner in the presence of a qualified radiologist. Take note that fetal development is a dynamic process, so the fetal organs can change appearance on a weekly basis. So for appropriate fetal MRI acquisition and image interpretation, again, I would like to emphasize that the radiologist has to know the developing fetal MRI anatomy so as to recognize pathology and also understand the short and long-term consequences of fetal abnormalities. I would like to congratulate our 2 fellows for tonight who have wonderfully presented to us imaging, fetal MRI imaging. Do you have any comments or questions?
Dr. Maricar,
Yes, Doc.
good evening. I would really like to congratulate our presenters today. Very wonderful cases presented by Dr. Alexa Uy, and excellent cases and excellent journal reporting by Dr. Carl Solidum. And of course, this would not be possible without the mentorship and supplemental information provided by Dr. Maricar Reyes, who is also our associate head for radiology at St. Luke's Medical Center Global City. I would like to share my experience about fetal MRI, which is quite lengthy. For as long as I've been doing radiology, I've been doing fetal MRI, and was the one who introduced this in St. Luke's Medical Center. No, in 2018, September of 2018, I was invited by the Federation of Asia and Oceania Perinatology Society. And the activity was in the Philippines and Manila Hotel. So all the major societies of perinatology all over the world convened in the Philippines at that time. And they had invited me to speak about fetal MRI. And I was confident because number one, we were doing it. And number two, we had enough cases, and the cases we had are really very good. And the protocol that we did was really appropriate. No? And Dr. Atin Polido Brillo was also one of our proponents because she presented this in several research fora before. Same with Dr. Nathan Concepcion. No? So we have a great team along with the other pediatric radiologist, Dr. Maricar Reyes. No? So I presented a 10-year experience of fetal MRI with this sea of people. And they were really impressed that we do it in the Philippines. But after my presentation, it was really the Filipino perinatologists and obstetricians who were asking, a lot of them did not even know that we do this in the Philippines. No? So we're not promoting it enough. And during the open forum, it came out, why is this procedure not popular in the Philippines? So number one, they did not know that it can be done because people, it's just not being promoted. And number two, if the perinatologist or the obstetrician asks the radiology department, the answer that they would get is that we don't know how to do it. No? And number three, if it was even done, the study was non-diagnostic, so they wasted a lot of money for nothing. And pang-apat lang yung expense, etc. Because when you already come to this particular scenario, ultrasound has done its job already. There's already a question that they wanted to answer because ultrasound was the first step and they needed to answer the questions even further. So MRI was really the next step. But, it's not being promoted, as I said. So with this particular presentation tonight, I hope our radiologists in the room will go ahead and promote fetal MRI to all of us. No, it's really a matter of the radiologist sitting in the console table and doing the protocol. It's like a cookbook, no? And if you have a question, you could reach any of the members of the PSPR or us, for consultation. But we have to start doing it because although we have ultrasound, OB ultrasound, that the radiologists are still doing it, more and more in big facilities, we're losing the hold of OB ultrasound. In fact, at St. Luke's, we don't do OB ultrasound anymore. But, that's the sign of times. It's just changing. So the way that we are able to get back fetal imaging, one of them would be fetal MRI. And that way, the obstetricians and perinatologists would develop better bonding with us, a better partnership with us if we start doing fetal MRI. So that is my sharing. Thank you.
Thank you po, Doc.
Thank you,
Actually,
Doc.
thank you, Doc. Actually, for this, yung fetal MRI, I inquired I would just like to share, I called up some big centers with MRI. So, ang alam ko po kasi we have been doing it in St. Luke since way back 2005. And then, Dr. Pulido is doing fetal MRI also in Perpetual kasi she's there, Pero I'm not so sure kung saan pa po ginagawa itong fetal MRI. But I called some big centers dito sa Metro Manila. Yung isa ang sagot sa akin was, ayo po, gumagawa na po kami niyan ngayon. So parang recently they have started na rin. Pero yung iba kahit big center, sabi sa akin, they don't do the fetal MRI. So I guess we really need to disseminate and the knowledge and the know-how para sa ating ibang radiologist colleagues. So, and with that, I would like to thank Dr. Pulido has something to say, Dr. Tin.
Sorry. Good evening, everyone. Congratulations to Dr. Alexa, Dr. Carl, and also Dr. Maricar for the excellent presentation. And also, I would like to thank, of course, Dr. Laya, Dr. Nathan, and Dr. Maricar, who were very patient with me during fellowship training, and which I carry up to now. And hopefully, have shared it with the trainees as well. And just to add to what was presented also, we could also, in addition to what Dr. Laya have said, we could also market fetal MRI with the portal of entry of maternal indications also, because I think they are more open with regard to how I have perceived the practice of obstetricians and other physicians as well. They are more open to the maternal indication as with for requesting fetal MRI. We have various experience with regards to hepatobiliary pathologies like cholecystitis. We had one case of Meritz syndrome as well, and appendicitis in pregnant women. And we have also encountered there's this one trauma patient, victim of hit and run, wherein she had pelvic fracture. So that's also a very good way of evaluating the maternal indications or the maternal side for fetal MRI. And also, you could as well check the fetus, the condition of the fetus as well. So there, that's it. Thank you.
Thank you, Doc.
Thank you, Dr. Tin. Si Dr. Tin, very passionate yan sa fetal MRI. So, with that, but before we go, Alexa, can you post muna yung ating poster? And we would like to invite whoever is interested to join the St. Luke's Medical Center, Quezon City, and Global City Radiology Residency Training Program. So we are now accepting applications. So please disseminate the information to your friends or relatives who might be interested in pursuing specialization in radiology. And if there are no other comments or questions,